Welcome to the Deep Dive. Today we're tackling a clinical scenario that every GP encounters regularly, one that can be both, well, common and critically important to navigate: chest pain.
Absolutely. It's a big one.
Especially for you listening, general practitioners and particularly GP registrars getting ready for those fellowship exams, the ability to efficiently and accurately sort through, benign discomfort versus life-threatening emergencies is just vital.
It really is. Chest pain presents a significant diagnostic challenge in primary care, doesn't it? Our goal today is, I suppose, to provide a framework for approaching this symptom. We're leaning heavily on John Murtagh's General Practice 8th edition, specifically Chapter 30.
Good old Murtagh.
Can't beat it. The aim is to equip you with those key insights for, well, confident and effective management.
Exactly. Think of this as your guided tour through the real essentials of that chapter. We want to pull out the core knowledge you need to feel properly prepared, both in clinic day-to-day and when you're facing those fellowship assessments. We're really aiming for clarity and actionable advice here.
Yeah, and it's really crucial to immediately establish the sort of high-stakes landscape. When a patient presents with spontaneous chest pain, there are several immediate life-threatening diagnoses that you must always consider and, frankly, rapidly exclude.
Okay, what are the big ones?
Well, you've got myocardial infarction, or MI, and unstable angina, which we now group under acute coronary syndromes, ACS. Then there's pulmonary embolism, PE, aortic dissection, and tension pneumothorax. These are the ones where time is absolutely critical.
Right, those are the cannot miss ones straight off the bat. Now, when we zero in on the possibility of, say, ischemic heart disease, the patient's story, that detailed history that becomes our most powerful initial tool, doesn't it?
Hugely powerful, especially when we're looking for that hallmark of angina,
Yeah.
symptom reproducibility.
Reproducibility. Tell us more about that.
Well, if the pain consistently comes on with a predictable level of exertion, like walking up 2 flights of stairs, and it reliably goes away with rest, or maybe with glycerol trinitrate, GTN, that's a highly significant pointer towards angina.
That predictability is key.
It really is. And it's vital to remember the clinical maxim. Unstable angina should be considered pre-myocardial infarction. It just highlights the urgency. Any new onset angina or angina that's getting worse, more frequent, or starting to happen at rest, you have to take that very seriously.
And as we all know, it's not always that straightforward, is it? Myocardial infarction can often present in ways that don't scream heart attack, maybe with atypical symptoms or even silently.
That's such a crucial point to keep hammering home. We need to keep it in mind, especially when assessing patients with diabetes, hypertension, older patients, and also women.
Why those groups particularly?
Well, these patient populations are just statistically more likely to present with symptoms like shortness of breath, maybe just profound fatigue, nausea, or perhaps epigastric discomfort rather than that classic crushing chest pain we often think of. So maintaining a really high index of suspicion is paramount.
Okay, let's pivot now. What about the things we see most frequently in the GP setting? The sort of probability diagnoses for chest pain. Murtagh's chapter highlights musculoskeletal or chest wall pain and psychogenic disorders as the most common.
That's right. Musculoskeletal pain, while it's very common, it can sometimes be, well, underappreciated or maybe misdiagnosed. Patients might call it fibrositis or neuralgia.
Right.
But it's important for us to think about specific causes. Things like costochondritis, that inflammation where the ribs meet the sternum or muscular strains, maybe dysfunction of the sternocostal joints, and really importantly, referred pain. Pain coming from the lower cervical or upper thoracic spine.
Referred pain from the spine. That's such a classic mimicker of cardiac issues, isn't it? It can really send you down the wrong path if you're not thinking about it.
It's a huge diagnostic challenge. You see, the complex network of nerves means that problems in the neck or upper back can definitely radiate pain around to the front, to the chest wall. So a thorough musculoskeletal examination is just essential.
And then there are psychogenic disorders. The chapter rightly points out they're pretty frequent too. It's a delicate balance though, isn't it? Acknowledging that psychogenic chest pain is real, but making sure we don't prematurely dismiss an underlying organic cause, especially when someone presents acutely.
That's a very, very important point. While anxiety and panic disorders can certainly manifest as chest pain, it really has to be a diagnosis of exclusion. We must rigorously investigate and rule out those potentially serious organic causes before attributing the pain solely to psychological factors.
Another condition mentioned that can be remarkably tricky to distinguish from angina is gastroesophageal reflux disease, or GOR. That burning retrosternal feeling can sound alarmingly similar.
It really can. Things like the timing of the pain often after meals, or worse when lying down and maybe getting relief with antacids can offer clues. But honestly, in patients with cardiac risk factors or maybe atypical presentations, you might well need further investigations to definitively separate GRD from cardiac ischemia.
And despite all these other possibilities, the chapter reinforces that angina is common and must always remain in our differential diagnosis. If that angina-like pain lasts longer than, say, 15 minutes, the urgency to rule out an MI ramps up significantly.
Yeah, that 15-minute duration serves as a really critical red flag. It should prompt a higher level of suspicion for ACS and the need for immediate investigation, definitely including an ECG. And as Murtagh's Table 30.1 summarizes, those initial probability diagnoses should cover musculoskeletal pain, psychogenic causes, GRD, and of course, angina itself.
Okay, let's move on to the serious disorders not to be missed. The chapter highlights what it calls the usual triad: malignancy, myocardial ischemia, and severe infections.
These represent, well, diagnostic imperatives. We've already talked a fair bit about myocardial ischemia, but we also need to be vigilant for those less common, but potentially catastrophic cardiovascular emergencies like dissecting aortic aneurysm and pulmonary embolism, especially in patients who have predisposing risk factors.
Right, and who might be at increased risk for those? For aortic dissection or PE? What are the key risk factors we should have in mind?
Okay, so for aortic dissection, think about pre-existing hypertension, that's a big one, connective tissue disorders like Marfan syndrome or Ehlers-Danlos, having a bicuspid aortic valve, or a family history of dissection. For PE, the classic risks include recent surgery or major trauma, prolonged immobility, active cancer, pregnancy, certain hormone therapies, and, of course, a previous DVT or PE.
The chapter also draws our attention to spontaneous pneumothorax, particularly in young, tall, slender males, often without any prior history of lung disease. That's quite a specific demographic to remember.
It is. When a young person presents with sudden onset chest pain and breathlessness matching that description, pneumothorax should jump right up the list. You might find decreased breath sounds on that side, and a chest x-ray, ideally an expiratory view, is how you diagnose it.
Now, lung malignancies. Probably not the first thing that springs to mind with chest pain, but the chapter mentions they can be a cause, especially if the tumor starts invading local structures like nerves or the spine.
That's an important one to keep in the back of your mind, particularly in patients with a significant smoking history or other risk factors like COPD. The pain might be more gradual in onset, often accompanied by other things like a persistent cough, maybe coughing up blood, hemoptysis, or unexplained weight loss.
And finally, within these serious disorders, we have severe infections. Murtagh lists pneumonia and pleurisy, pericarditis, and mediastinitis as potential causes of significant chest pain.
Yeah, these infections cause pain through inflammation. Pneumonia and pleurisy often come with cough, fever, sometimes nasty sputum, and that sharp pleuritic pain that's worse with breathing. Pericarditis might give you a sharp retrosternal pain that characteristically feels better when leaning forward, and you might hear that classic pericardial friction rub. Mediastinitis is less common, often after surgery or maybe esophageal perforation, and presents with severe central chest pain and signs of systemic infection.
Okay, let's dig into the pitfalls now, those commonly missed diagnoses. The chapter kicks off by stating, quite starkly actually, that myocardial infarction and angina are frequently overlooked. That's quite sobering.
It is sobering, and it just underscores how vital it is to maintain that high index of suspicion for cardiac ischemia, especially with atypical symptoms or multiple risk factors.
Yeah.
And as we mentioned earlier, that referred pain from spinal dysfunction, particularly the lower cervical spine, is another major pitfall. It can really mimic cardiac pain because it presents on the anterior chest wall.
Yeah, that anterior referral is so misleading, isn't it? It feels like the pain is coming right from inside the chest.
Exactly. The key often lies in a careful history, focusing on what makes it worse or better. Spinal pain is often aggravated by specific neck or back movements, unlike typical angina, which is primarily exertional. Other pitfalls mentioned include things like a cough fracture of a rib, especially in older or osteoporotic patients, or herpes zoster, shingles, presenting with pain before the rash appears.
The preherpetic neuralgia.
Precisely. And then there are GI conditions like esophageal spasm, reflux, and even gallbladder issues called cystitis or biliary colic, where the pain can sometimes radiate up into the chest.
Cholecystitis presenting as chest pain? That's an interesting one. How does that happen?
Well, the pain from gallbladder inflammation usually starts in the right upper quadrant or epigastrium, but because of shared nerve pathways, it can sometimes refer pain up to the chest or maybe the right shoulder or back. It can occasionally be misinterpreted as cardiac, which just highlights why a good abdominal exam is part of the chest pain workup.
The chapter also brings up mitral valve prolapse, MVP, as a potential cause, particularly in younger women who might also get palpitations and feel anxious. The pain is often described quite differently: sharp, fleeting, not related to exertion, and often felt near the apex of the heart.
That's a very typical description associated with MVP. The exact reason for the pain isn't fully clear, maybe related to stretching of the valve apparatus. It's something to consider in the right demographic, and an echocardiogram can help confirm it.
Okay, moving to general pitfalls. The chapter hammers home the need to be coronary aware in all patients presenting with acute chest pain. It's a good mantra for primary care, isn't it?
Absolutely. Until you've confidently ruled out a cardiac cause, ACS has to stay high on your differential list. The chapter also, again, reiterates that issue of overlooked referred pain from lower cervical spine disorders, just reinforces the need for a really comprehensive assessment, including the musculoskeletal system.
Another big general pitfall mentioned is prematurely blaming psychological factors in patients known to have anxiety. It's easy to do, but we have to guard against it, especially with new or acute chest pain.
That's crucial, avoiding that diagnostic anchoring bias. Yes, anxiety can cause chest pain, but we must first rigorously exclude underlying organic pathology before concluding it's purely psychogenic. A thorough history, exam, and usually an ECG are essential.
The chapter also kind of debunks that old chestnut that pain radiating down the inside of the left arm automatically means it's cardiac.
You're right. While left arm pain, especially with exertion, is definitely suggestive of cardiac ischemia, it's not pathognomonic. It can also be caused by nerve compression, cervical spine issues, or other musculoskeletal problems. It's a clue, but not proof.
Finally, under general pitfalls, the reminder that up to 20% of MIs can be silent, especially in older adults, and that PE can even occur without chest pain if it mainly involves the big pulmonary arteries. These silent presentations are tough.
They really are. And they just highlight why we need to consider risk factors and be proactive with investigations, even without classic pain, particularly in high-risk individuals, diabetics, the elderly, those with known cardiovascular or thromboembolic risks.
Let's shift focus now to psychogenic considerations. The chapter describes psychogenic pain as often occurring, well, anywhere in the chest, but frequently in that left submammary region and typically without radiating anywhere else. It tends to be continuous, sharp, or stabbing, quite different from the constricting or pressure-like pain of ischemia.
That's a useful clinical distinction. The quality, the pattern, the duration, they can all provide clues towards a psychogenic origin. As the chapter notes, psychogenic chest pain, especially during a panic attack, often comes with other symptoms: palpitations, hyperventilation, or feeling short of breath, fatigue, tremor, agitation, and obviously significant anxiety.
And the triggers are often different too, aren't they? Often linked to stress, emotional tension, anxiety, or underlying depression, rather than physical exertion. And the pain itself can last for hours or even days.
Exactly. Looking at the broader psychosocial context, any history of anxiety or mood disorders and the presence of those associated symptoms can all point towards a psychogenic cause. But, as we stressed multiple times now, only after ruling out organic causes.
Right. Okay, let's get practical. The clinical approach, starting with the history. Murtagh rightly emphasizes that a meticulous history is just paramount, and it recommends using the Socrates system as a structured framework.
Yeah, Socrates is great for anyone needing a refresher. Site, onset, character, radiation associations, time course, exacerbating relieving factors, and severity.
Using a system like that ensures we cover all the bases, doesn't it? Building that detailed clinical picture.
Definitely. And the history should also dig into any associated serious medical problems: diabetes, Marfan syndrome, anemia, connective tissue disorders like lupus or rheumatoid arthritis, plus a really thorough exploration of cardiovascular risk factors.
The chapter does acknowledge the challenge of getting a detailed history when someone's in severe acute pain, though. Priorities shift then.
Oh, absolutely. In that acute setting, the initial focus has to be on rapidly assessing and ruling out those immediate life threats. But as soon as the patient is stable enough, that comprehensive history becomes invaluable for guiding what comes next.
The chapter then highlights some important associated symptoms that should raise our suspicion for specific diagnoses. For instance, syncope fainting, along with chest pain, should make us think MIPE or Aortic dissection.
Yeah, syncope with chest pain is a major red flag. It suggests potential hemodynamic compromise and needs urgent evaluation for those big cardiovascular causes.
Similarly, pain that's clearly worse on inspiration breathing in should point us towards things like pleuritis, pericarditis, mediastinitis, pneumothorax, or maybe musculoskeletal chest wall pain.
That worsening with a deep breath is a key feature when the pleura or chest wall structures are involved.
And if someone has thoracic back pain at the same time as chest pain, that really broadens the differential, doesn't it? Includes spinal dysfunction, ACS or angina, aortic dissection, pericarditis, even GI things like peptic ulcers, biliary colic, or esophageal spasm. That's a lot.
It is a lot, and it just underscores how important it is to think about referred pain patterns and how different organ systems can connect when you're evaluating chest pain.
Okay, so Murtagh gives a list of key questions to ask patients. Basic stuff first. Where exactly is the pain? Can you point to it? Does it travel anywhere? Getting a really careful description of the pain's quality.
These fundamental questions are crucial for characterizing the pain. The radiation pattern, as we've said, can be really helpful in differentiating cardiac from non-cardiac sources, and understanding how the patient describes it, sharp, dull, crushing, burning, tight, helps narrow things down.
And duration, how long did it last? What triggered it? Did anything make it better? These time characteristics and modifying factors are often absolutely key.
For sure. Exertional pain relieved by rest screams angina, right? Whereas pain that just goes on for hours or days without clear triggers or relieving factors might point more towards musculoskeletal or maybe psychogenic causes.
And specific questions like, does exertion bring it on and rest relieve it? Does cold weather trigger it? These directly target that classic angina pattern.
Yep, vital questions when you're assessing for possible cardiac ischemia.
And obviously we need to ask about any other symptoms: breathlessness, feeling faint or lightheaded, fever, nausea, vomiting, dizziness, unexplained weight loss, sweating, back pain. These add layers to the picture.
Definitely. Exploring associated symptoms helps build that complete clinical picture and identify patterns suggestive of specific conditions.
Questions about worsening factors. Is it worse when you breathe deeply or cough?
Yeah.
Worse with movement, worse if you press on the area. That helps sort out musculoskeletal or pleural involvement. And asking about blood and the sputum hemoptysis, that's a potential red flag for lung issues.
Exactly. Helps differentiate chest wall pain from visceral pain and can point towards respiratory causes.
And finally, don't forget the GI angle. Any link to eating or drinking. A bitter taste. Worse, bending over or lying flat at night. Does Gaviscon or an antacid help? These all point towards DORD. And always ask about any recent rash thinking, shingles, or any recent injury to the chest or back.
Yeah, a really comprehensive, targeted history using a structure like Socrates and exploring all these angles, it really forms the bedrock for getting the diagnosis right.
Okay, let's move on to the examination part of the clinical approach. The chapter outlines several critical areas, starting with general appearance, looking for signs of atherosclerosis, like corneal arcus, feeling for thickened arteries, noting pallor or sweating, or even neurological signs like a hemiparesis, which could hint at aortic dissection.
The patient's overall look can give you instant clues. Pallor and sweating can go with significant pain or a major cardiovascular event. Hemiparesis with chest pain is a serious red flag for dissection affecting the brain's blood supply.
Palpating pulses, radial and femoral, checking their character, comparing sides, and specifically looking for absent or weak femoral pulses, which is a classic sign in aortic dissection. And obviously, a full set of vital signs. Blood pressure in both arms, heart rate, respiratory rate, temperature, oxygen sats.
That blood pressure difference between arms, or those diminished femoral pulses, critical signs suggesting dissection. Vitals give you that immediate objective snapshot of how sick the patient is.
Palpation of the chest wall itself and the lower cervical and thoracic spine is crucial. Feeling for localized tenderness, suggesting MSK origin, maybe a fracture, or spinal dysfunction. Keeping an eye out for that vesicular rash of shingles, and feeling the legs for signs of a DVT swelling, redness, tenderness, especially if PE is on your mind.
A careful musculoskeletal exam often nails the source of chest wall pain, and finding a DVT massively increases the odds of a PE.
Examining the chest itself, looking for asymmetry of movement. Then auscultation of the lungs is vital. Listening for reduced breath sounds, maybe a hyperresonant percussion note, decreased vocal fremitus, all suggestive of a pneumothorax.
Those are the classic findings, yeah. Air in the pleural space squashing the lung.
Then listening to the heart. Can you hear a pericardial friction rub? That's key for pericarditis, or sometimes pleurisy if the inflammation spreads. Basal crackles might mean heart failure. An apical systolic murmur could be MVP. An aortic diastolic murmur might point to aortic regurgitation from a proximal dissection. Wow, you can get a lot from careful listening.
It's true. And the chapter makes a really important point. In early MI, the exam can be completely normal, but
Okay.
later you might see signs of shock, cold, clammy, muffled heart sounds, maybe an S3 or S4 gallop, or a new murmur if a papillary muscle is struggling. Similarly, with aortic dissection, they might be shocked, have those absent femoral pulses, maybe neurological signs, and that diastolic murmur.
And finally, don't forget to palpate the upper abdomen for tenderness that might suggest gallbladder disease or a peptic ulcer masquerading as chest pain.
Exactly. A thorough physical exam, tying the findings back to the history, is essential for building that differential and deciding on investigations.
All right, let's talk investigations. The chapter stresses that while there are tons of fancy tests, the fundamental tools for GPs, the 12-lead ECG, the chest X-ray, and cardiac enzymes are often pivotal. And the crucial takeaway, anyone with undifferentiated chest pain needs a 12-lead ECG, pronto.
The ECG is absolutely the cornerstone of that initial workup. It's available in most practices and can give you vital clues about ischemia, infarction, arrhythmias, even other things like pericarditis or PE.
Focusing on the electrocardiogram ECG itself, the chapter says it can be diagnostic for ischemia and MI. But, and this is a big, but it can also be totally normal, especially really early on in an MI or in unstable angina.
That's a critical caveat. A normal initial ECG absolutely does not rule out ACS. If your clinical suspicion is high based on the story and exam, you need serial ECGs and cardiac biomarkers. The ECG can also help differentiate MI from PE or pericarditis. For instance, a massive PE might show right heart strain signs, right axis deviation, RBBB. Pericarditis often has that diffuse concave ST elevation and PR depression.
The exercise stress test is mentioned as a key follow-up test if you suspect cardiac pain, trying to provoke symptoms under controlled conditions while watching the ECG.
Correct. It helps identify significant coronary artery disease by showing ECG changes of ischemia during exertion. But again, a negative test doesn't completely rule out CAD, especially if it's single vessel disease or the test wasn't maximal.
The exercise thallium scan is mentioned as complementing the exercise ECG, especially useful if the baseline ECG is tricky to interpret, like with LBBB, a previous MI, WPW, or MVP.
Yeah, thallium is a tracer taken up by healthy heart muscle. During the scan, areas of reversible ischemia show up as cold spots during exercise that fill in at rest. It tells you about perfusion and viability.
Ambulatory ECG Holter monitoring, useful for catching things that might not show up on a single resting ECG, right? Like silent ischemia, variant angina, or arrhythmias causing symptoms.
Exactly. Monitoring for 24 or 48 hours catches those intermittent events missed on a 10-second strip. Good for unexplained palpitations or suspected vasospastic angina.
A routine chest X-ray, important baseline test done in full inspiration, and an expiratory film if you suspect a pneumothorax.
The chest X-ray helps spot a whole range of non-cardiac causes: pneumonia, pneumothorax, pleural effusion, maybe a widened mediastinum suggesting dissection. It also gives you an idea of the heart size and lung vasculature.
Basic bloods too, blood glucose, and hemoglobin and blood film. Checking for diabetes, which increases risk and can cause atypical MI presentations, and anemia, which can worsen angina.
Yep, routine bloods give important context and might identify contributing factors or risks.
Then we get to serum enzymes, the cardiac biomarkers. Troponin T and I are highlighted as the key ones because they're so specific to heart muscle injury. We need to know their typical rise and fall pattern. CK, CKMB, and myoglobin are also mentioned as earlier but less specific markers.
Troponin is definitely the preferred biomarker now for diagnosing MI. Understanding that time course rising in 3-12 hours, peaking around 24, staying up for 5-14 days is crucial for interpretation. CKMB rises earlier but isn't as specific and normalizes faster.
Transthoracic echocardiography, the standard echo. Useful for seeing wall motion problems early in MI, even if the ECG and enzymes aren't diagnostic yet.
Exactly. And transesophageal echocardiography, TOE, gives a better view of the back of the heart and the aorta, making it more sensitive for diagnosing aortic dissection, checking prosthetic valves, or looking for sources of emboli.
Echo gives you that real-time look at structure and function, ischemia, valve problems, pericardial fluid. And TOE is often the go-to for suspected dissection, if available quickly.
Right. Then there are various isotope scanning techniques mentioned. Technetium 99-meter pyrophosphate scanning can light up areas of acute MI, especially useful for certain types or if there is LBBB. It can also be used for PE diagnosis, VQ scan, Gated blood pool scans, like MUGA, assess left ventricular function.
These nuclear scans provide extra info in specific situations, maybe if other tests are unclear or you need to assess heart muscle viability.
Then you have angiography, arteriography, coronary angio, pulmonary angio, CT angiography, CTA, MR angiography, MRA. More invasive or specialized tests to directly look at the arteries.
Angiography is still the gold standard for definitively diagnosing CAD and PE. CT and MR angiography are less invasive alternatives gaining ground, giving great anatomical detail.
The coronary calcium scan is a non-invasive CT scan measuring calcium in the coronary arteries. A high score means higher risk of future heart attacks, while a score of 0 suggests a very good outlook in the medium term.
Right, so not for acute pain, but useful for risk stratification in stable patients or even asymptomatic ones to assess their underlying CAD risk.
Exactly. And finally, the chapter lists esophageal studies, endoscopy, barium swallow, manometry for when you strongly suspect an esophageal cause, and spine x-ray if referred musculoskeletal pain seems likely.
So investigations targeted based on your clinical suspicion from the history and exam.
Precisely. A logical stepwise approach.
This has been an incredibly thorough run-through of the initial assessment and investigations. It really highlights that systematic approach. Detailed history, careful exam, and smart use of those core investigations. ECG, CXR, troponin, that's the foundation for GPs.
Absolutely. Understanding the subtleties of different presentations, spotting those red flags for serious stuff, and knowing when and how to use further tests, these are crucial skills for all of us, and especially for you preparing for fellowship exams.
Okay, now let's dive even deeper into the specific features of some key chest pain syndromes, really getting into the nitty-gritty from the chapter, starting with myocardial ischemia. Talk us through the typical site and radiation.
Right, so the classic location is retrosternal, behind the breastbone. But the chapter emphasizes that pretty much any anterior chest pain should be considered cardiac until proven otherwise. And the radiation is incredibly variable. It can go anywhere from the umbilicus up to the jaw, neck, down the arms, into the epigastrium, even between the shoulder blades.
Left arm is more common than right, but pain in both arms is actually the best predictor of an AMI.
That's what the evidence suggests, yes. And conversely, pain that's pleuritic, worse on breathing or sharp, or pain that you can reproduce by pressing on the chest wall, those features make AMI less likely.
What about the quality of ischemic pain?
Typically described as pressure, heaviness, tightness, constriction. The Levine sign, the patient making a clenched fist over their sternum, is a classic visual cue. The radiation pattern can help distinguish it from pericarditis, and the precipitating and relieving factors help differentiate it from referred spinal pain.
And associated symptoms.
Common ones are shortness of breath, dyspnoea, dizziness or lightheadedness, nausea, vomiting, and sweating, diaphoresis.
How do we reliably differentiate it from esophageal reflux or spasm, which can mimic it so closely?
It's tricky. Esophageal pain is often precipitated by bending, lifting, straining, or lying down, especially after meals, rather than pure physical exertion like classic angina.
Okay, let's break down the types. Stable angina.
Typically lasts just a few minutes, average 3 to 5. Reliably relieved by rest or GTN. Sometimes precipitated by arrhythmias, too.
And the acute coronary syndromes, ACS. Murtagh uses table 30.2 here. Can you walk us through the main categories?
Sure, so ACS is the umbrella term. Underneath you have unstable angina, which can be low or high risk. ECG and CK are usually normal, but troponin might be detectable in high-risk cases, maybe with some ST depression. Then NSTEMI, non-ST elevation MI. Here you have elevated CK and troponin, often ST depression on the ECG, but no pathological Q waves. And finally, STEMI-ST elevation MI. Elevated enzymes again, but now with characteristic ST segment elevation on the ECG, potentially developing Q waves, or sometimes a new left bundle branch block, LBBB.
So for a classic myocardial infarction, the pain duration is key.
Yes, typically ischemic pain lasting longer than 15-20 minutes, though it can sometimes resolve quicker or last for many hours. The quality is usually that heavy, crushing feeling. Intensity varies massively. Importantly, it can be painless, especially in diabetics. And those associated signs, pallor, sweating, vomiting, are common.
And unstable angina specifically, how is that defined?
It includes angina occurring at rest, new onset effort angina that's quite severe, or angina happening soon after an MI or a procedure. The pain is typically severe ischemic pain lasting over 15-20 minutes. It gets classified as low or high risk, sometimes referred to as minor myocardial damage if troponin is slightly elevated.
So clinically, the big split for immediate management is classifying acute ischemic chest pain as either STEMI or non-NST elevation ACS, NSTEGs, which includes anstemy and unstable angina.
Exactly. That distinction drives the initial management pathway, particularly regarding urgent reperfusion strategies.
Okay, moving on to aortic dissection. What's a classic picture there?
Think sudden, severe, unrelenting pain, often described as tearing or ripping, typically midline, retrosternal, or maybe between the shoulder blades.
And radiation.
It characteristically radiates often down to the abdomen, flank, or legs. A really key sign is unequal pulses. Check carotid, radial, and especially femoral pulses carefully. There might also be complications like coronary or renal artery occlusion, neurological deficits like hemiplegia, new aortic incompetence murmur, or even cardiac tamponade if it ruptures into the pericardium.
Investigations for suspected dissection.
Urgent imaging is needed. Transesophageal echo, TOE, is often best for rapid bedside diagnosis if available. CT angiogram or MRI are also key.
Next up, pulmonary embolism, PE.
Often a dramatic onset, especially if a large clot blocks the main pulmonary artery or a major branch affecting more than 50% of the cross-sectional area.
And the types.
Murtagh classifies them as massive PE causing shock or hypotension, BP 90 millimole Hg. Submassive PE, where there's evidence of right ventricular dysfunction but blood pressure is maintained. And non-massive PE, which is lower risk.
Diagnosis can be tricky, though.
Very tricky sometimes. Patients might just present with dysmelia without pain, or even be asymptomatic if it's small. The typical pain, if present, is usually retrosternal. Syncope or severe breathlessness can occur. A massive PE can present with profound hypotension, acute right heart failure, even cardiac arrest. And frustratingly, the physical exam can sometimes be deceptively normal.
What about pulmonary infarction?
That's less dramatic, usually complicates about 10% of embolisms, presents with pleuritic chest pain, sometimes hemoptysis.
Key diagnostic tests for PE.
CT pulmonary angiogram, CTPA, is generally considered the best initial imaging test now. VQ scanning is an alternative, especially if CTPA is contraindicated. ECG might show signs like T-wave inversion in V1-V4 or right heart strain, but can be normal. Risk stratification scores like the Wells score are very helpful, and a negative D-dimer test can help rule out PE in patients deemed low risk by the score.
Okay, let's talk about pleuritis or pleurisy.
This is inflammation of the pleura, the lining around the lungs. Causes include infection, pneumonia, viral or bacterial, pulmonary infarction, tumor infiltration, or connective tissue diseases like lupus.
Clinical features.
Often sudden onset. Usually localized pain doesn't tend to radiate far. It's sharp, often described as knife-like. It's typically continuous but with sharp spikes and characteristically aggravated by deep inspiration, sneezing, or coughing. May also have dyspnea, cough, or hemoptysis, depending on the underlying cause.
What about epidemic pleurodynia or Bornholm disease?
Ah, yes, the devil's grip. This is usually caused by Coxsackie B virus, often after an upper respiratory infection. Presents with quite severe unilateral knife-like intermittent pain in the chest or upper abdomen, often associated fever, malaise, headache. Muscles in the trunk might be tender. Chest x-ray is normal. It's really a diagnosis of exclusion. Settles in about a week with simple analgesics, though recurrences can happen.
And acute pericarditis.
Inflammation of the pericardium, the sac around the heart. Presentation depends on the cause. Viral is commonest, but also connective tissue disorders, bacterial infection, viremia, post-MI, Dressler syndrome later, or idiopathic.
Symptoms and signs.
Patients might have fever, malaise, fatigue, anxiety. Key signs are tachycardia, maybe a paradoxical pulse, and crucially, a pericardial friction web on auscultation. Investigations usually include ECG, chest x-ray, and echocardiogram.
What about the pain in pericarditis?
There are three main types described. 1, pleuritic pain. This is the commonest. Sharp pain, worse with cough, deep breath, or lying flat, classically relieved by sitting up and leaning forward. 2, steady, crushing retrosternal pain. This can radiate to the neck and arms, really mimicking an MI. 3, pain synchronous with the heartbeat, felt over the precordium or left shoulder.
And the cardinal sign.
The pericardial friction rub. It sounds like scratching or grating, often best heard with the diaphragm of the stethoscope with the patient leaning forward. But it can be transient, so you might miss it. Depends on the cause. But for idiopathic or viral pericarditis, often colchicine for about 3 months, plus high-dose aspirin or ibuprofen for 1-2 weeks.
Spontaneous pneumothorax. We touched on this earlier.
Right. Acute onset of pleuritic pain and dyspnea, Often a history of asthma or emphysema is a hallmark, due to rupture of a bleb or cyst, but classically occurs in young, slender males without prior lung disease history.
Pain characteristics.
Can vary hugely, mild to severe. Can be felt anywhere in the chest, sometimes retrosternal. Diagnosis is confirmed on chest x-ray, ideally an expiration film to make it more obvious.
And tension pneumothorax.
This is the emergency. Painful, rapidly worsening dysmia, shock. Air gets in but can't get out, collapsing the lung and pushing the mediastinum across, compromising the heart and great vessels. Needs urgent decompression with a large bore needle. Murtagh includes a useful table, table 30.3, comparing these serious causes.
Let's switch gears to esophageal pain, D or D, first.
Gastroesophageal reflux typically causes a burning epigastric or retrosternal pain, sometimes radiating up to the jaw. Often aggravated by lying flat or bending over, especially after meals, and frequently worse at night. If someone has sudden severe pain after an endoscopy, you have to consider esophageal rupture.
And esophageal spasm.
This can make reflux pain worse or occur on its own. The pain can sometimes radiate through to the back, which is less common with GORD alone. It can be precipitated by eating, especially very hot or cold foods. Interestingly, it can sometimes be relieved by eating or by GTN or other nitrates, which adds to the confusion with angina.
Murtagh has tables differentiating esophageal and cardiac pain, table 30.4, and listing GI causes, table 30.5. Useful references.
Very useful. The subtle differences in triggers, relieving factors, and associated symptoms are key.
What about spinal pain referred to the chest?
Murtagh states, this is likely the commonest cause overall. Vertebral dysfunction of the lower cervical or upper dorsal thoracic region, usually from facet joint or costovertebral joint dysfunction causing referred pain, rather than disc prolapse, which is common lower down in the neck but rare in the upper thoracic spine.
And the referred pain pattern?
It can literally be anywhere in the chest wall, including anteriorly, perfectly mimicking cardiac pain. The pain is often described as dull or aching, and typically aggravated by exertion involving the upper body, certain movements of the neck or back, or sometimes deep inspiration if the costovertebral joints are involved. And always remember herpes zoster for unilateral nerve root distribution pain.
Costochondritis.
This is usually mild to moderate anterior chest wall pain, sometimes radiating more widely to the chest, back, or abdomen. Often unilateral, sharp, and made worse by breathing, activity, or certain positions. It might follow unusual exercise or a viral infection and can grumble on for months. Diagnosis is clinical finding tenderness right over the costochondral junctions. Need to differentiate it from Tietze syndrome, which involves actual tender swelling of the cartilage.
And psychogenic pain, again, briefly.
Can occur anywhere. Often left submammary region, usually doesn't radiate. Typically continuous, sharp or stabbing, lasting hours or days, often aggravated by tiredness or emotional tension, and may come with breathlessness, fatigue, palpitations. Da Costa syndrome or effort syndrome is mentioned, recurrent stabbing, left submammary pain with anxiety features.
And Takotsubo cardiomyopathy.
The broken heart syndrome. Presents acutely with chest pain and breathlessness, often mimicking an anterior MI on ECG. It's thought to be due to a surge of catecholamines after significant emotional or physical stress, causing temporary stunning and ballooning of the apex of the left ventricle. Treatment involves supportive care like aspirin, beta blockers, ACE inhibitors, and most people recover fully.
What about chest pain in children? Murtagh has table 30.6.
It's rarely due to serious pathology, but still important to evaluate properly, especially in adolescents. The mean age of presentation is around 12 years.
Commonest causes.
Often the exact cause remains unknown, possibly psychogenic. Common identified causes include musculoskeletal pain, cough-induced pain, costochondritis. Psychogenic causes often linked to hyperventilation and asthma. There's a bit of an age split. Younger children, 12, are more likely to have cardiorespiratory causes like cough, asthma, pneumonia, or rarely congenital heart disease. Adolescents are more likely to have psychogenic causes.
Musculoskeletal in kids.
Usually strains pectoral, shoulder, back muscles after exercise or sports. Miter trauma is common. Also, remember, breast development issues, mastalgia, can present as chest pain in adolescents.
Cardiac causes in children.
MI is incredibly rare, but needs consideration with exercise-induced pain, especially in adolescents with long-standing diabetes or children with sickle cell disease. Much more common is precordial catch syndrome, also known as Texidor's twinge or a stitch in the side. It's very common, causes sudden, sharp, localized pain, usually in the lower left chest, lasting 30 seconds to 3 minutes. Often related to posture or occurs with exercise, relieved by straightening up, taking slow, deep breaths, or sometimes by holding breath or shallow breathing. Benign.
And chest pain in the elderly.
This is a very important symptom because the prevalence of life-threatening cardiovascular conditions, MI, angina, dissecting aneurysm, increases significantly with age. Angina or MI are the most likely causes, but also need to consider herpes zoster, cough fracture, malignancy, pleurisy, PE, and GORD more frequently in this age group.
Okay, let's really drill down into angina pectoris now, perhaps with an emphasis on how it presents and is managed. Relevant for that elderly population, but also broadly applicable. Murtagh has table 30.7.
Right. Incidence is around 2–3% in the 25–64 age group, higher in older adults. The history is absolutely the basis of diagnosis.
Key features of the history for angina.
Often described as an oppressive discomfort rather than sharp pain. It's transient, usually lasting less than 10 minutes. Mainly retrosternal, but classic radiation to the arms, left more than right, jaw, throat, or back. May be associated with breathlessness, nausea, faintness, or sweating. Crucially, occurs during exertion or emotional stress, sometimes after meals or in cold weather, and it's reliably relieved by rest within minutes.
Physical exam.
Usually not helpful unless you happen to examine them during an attack, when you might see tachycardia or BP changes.
Differential diagnoses to consider.
Key ones include mitral valve prolapse, esophageal spasm, and dissecting aneurysm.
Main causes of angina.
Coronary artery atheroma is by far the most common. Others include valvular lesions like aortic stenosis, rapid arrhythmias reducing filling time, severe anemia reducing oxygen supply, and rarer causes like vasculitis or trauma.
What about the different variants of angina?
You have stable angina, predictable pattern, unstable angina, also called crescendo angina, pre-infarct angina, or acute coronary insufficiency, basically worsening pattern, occurs at rest, or new onset severe angina. Nocturnal angina, wakes patient at night. Decubitus angina occurs on lying down, and variant or Prinzmetal's angina, which is due to coronary artery spasm, typically occurs at rest and causes transient ST elevation on the ECG.
Okay, aids to diagnosis for angina, the ECG.
Can be completely normal between attacks, or it might show evidence of old ischemia or infarction. During an attack, you might see ST depression, T-wave inversion, or sometimes tall, upright T-waves, figure 30.12, but there's no single ECG finding specific only to angina.
Exercise ECG.
Useful. It's positive in about 75% of patients with severe coronary artery disease. But remember, a normal test doesn't rule out CAD.
Exercise thallium scan.
Helpful when the baseline ECG is abnormal, like LBBB, old MI, WPW, or for assessing reversible ischemia.
Holter monitoring.
Good for catching intermittent rhythm disturbances or suspected variant angina.
Gated blood pool scan, MUGA.
Assesses ejection fraction, giving a measure of overall left ventricular function.
Echocardiography.
Can show wall motion abnormalities suggestive of ischemia or old infarct, assess valvular function, and look at the pericardium.
And coronary angiography.
This is the gold standard for visualizing the extent and severity of coronary artery disease, figure 30.13. CT angiography is emerging as a safer alternative for diagnosis in many cases. It's important to note, though, the severity of angina symptoms doesn't always correlate perfectly with the extent of disease seen on angiography.
When is angiography indicated? Murtagh lists indications in table 30.8.
Key indications include things like a strongly positive stress test suggesting high-risk disease, suspected left main stem disease, angina that's not controlled well with medication, angina that's suspected but not definitively proven by non-invasive tests, patients presenting with acute coronary syndromes, angina occurring after an MI, and patients with valve disease over age 30 needing surgery to check coronaries at the same time.
Let's talk management of stable angina. What's the approach?
It's multifaceted. Firstly, prevention through risk factor modification, smoking cessation, weight management, diet, exercise, controlling hypertension and diabetes, managing lipids. Secondly, general advice. Reassure the patient about prognosis, address the risk factors, encourage activity like walking daily, advise exercising up to the angina threshold, stress management, avoiding known precipitants, but importantly, not restricting their lifestyle excessively.
And medical treatment for an acute attack or episodic angina.
Nitrates are key. Sublingual GTN tablets or spray, or a sublingual isosorbide dinitrate. Aspirin can also be used. If nitrates aren't tolerated, a short-acting nifedipine capsule might be an option. There are important tips for using GTN call ambulance if no relief after 3 doses over 15 minutes. Warn about headache, advise sitting down, storage advice, and the critical interaction with PDE5 inhibitors like sildenafil.
And for prevention of angina attacks.
For moderate stable angina, the usual starting point is aspirin plus a beta blocker like atenolol or metoprolol, possibly with regular nitrates added, like a GTN patch or long-acting isosorbide mononitrate. Important to aim for a nitrate-free period each day to avoid tolerance.
What if that's not enough? For persistent angina.
If a beta blocker isn't fully controlling it, you'd typically add a dihydropyridine calcium channel blocker, like slow-release nifedipine or amlodipine, plus nitrates. If beta blockers are contraindicated, you might use a non-dihydropyridine CCB instead, like diltiazem or verapamil, but be cautious combining verapamil and beta blockers.
And for refractory stable angina.
Options include adding drugs like nicorandil, perhexaline, needs monitoring, or ivabradine. Definitely time for specialist advice here. Unstable angina requires hospital admission, often IV nitrate therapy, aiming to optimize medical treatment and consider angiography for a potential corrective procedure.
Murtagh lists some rules of practice for angina meds, key points.
Right. For variant spasm angina, nitrates and CCBs are preferred. Avoid beta blockers. Avoid combining verapamil and beta blockers due to risk of heart block failure. Don't combine dihydropyridine and non-dihydropyridine CCBs. Manage nitrate tolerance by having a nitrate-free interval. Consider newer agents like nicorandil or ivabradine. Use prophylactic nitrates before known exertional triggers. And crucially, avoid nitrates if the patient has recently used phosphodiesterase inhibitors for erectile dysfunction. Sildenafil, vardenafil, tadalafil timeframes vary.
What about non-medical treatment?
Percutaneous coronary intervention, PCI, or angioplasty, PTCA, involves using a balloon to dilate the narrowed artery, figure 30.14. Complications include acute occlusion, rare, 2-4%, and restenosis, about 30% within 6 months with balloon alone.
And stents.
Intracoronary stents are now usually placed after balloon angioplasty, figure 30.15. They act as scaffolding to keep the artery open. They definitely reduce angina symptoms in stable angina and reduce death MI rates in ACS. You have bare metal stents, BMS, or drug-eluting stents, DES, which release medication to reduce restenosis. DES require longer courses of dual antiplatelet therapy. Aspirin plus clopidogrel or newer agents like ticagrelor or prasugrel. Specialist advice is crucial here.
And the other main option, coronary artery surgery, CABG.
Bypass surgery. Uses grafts, typically the saphenous vein from the leg, figure 30.16, or the internal mammary artery from the chest wall, figure 30.17, to bypass the blockages. Significant left main stem obstruction generally warrants bypass. Patients with severe 2 or 3 vessel disease and good heart function might be considered for either PCI or COBG, depending on various factors.
Okay, that's a comprehensive look at angina. Now let's tackle myocardial infarction, MI, in detail. Clinical guidelines first.
Key points. The pain is variable, sometimes mistaken for indigestion. Often similar location to angina, but usually more oppressive, severe, sometimes described with a sense of impending doom, anger, or anomie. Around 20% have no pain, silent parkas, particularly common in females, the elderly, diabetics, and hypertensives. These have higher mortality. A shocking statistic. 60% of MI deaths occur pre-hospital, often within the first 2 hours. Hospital mortality is now around 8-10%. There's a peak incidence between 6 a.m. and 10 a.m. Diagnosis usually requires 2 out of 3 criteria: typical prolonged ischemic pain history, characteristic ECG changes, and a typical rise and fall pattern of cardiac enzymes, biomarkers.
What's the underlying etiology?
Usually thrombosis forming on a ruptured atherosclerotic plaque leading to occlusion. Other causes include hemorrhage under a plaque, the plaque rupture itself triggering spasm, or coronary artery spasm alone, less common.
Signs on examination.
Can range from no abnormal signs at all to the patient looking pale, gray, clammy, short of breath, restless, and apprehensive. Blood pressure is variable, can be low if there's pump failure. Pulse is also variable. Bradyarrhythmias are common. You might hear signs of mild heart failure like an S3 or S4 gallop sound or basal crackles in the lungs.
Investigations for MI. Let's focus on the ECG again. What are the classic findings?
The ECG is most valuable for full-thickness transmural infarcts, which typically cause Q waves to develop. Pathological Q waves are broad and deep, usually defined as 0.04 is wide and 25% of the R wave height. They are abnormal unless seen in leads AVR, V1, or sometimes lead 3. Remember, Q waves can occur in other conditions too, like WPW, VT. After an AMI, Q waves usually persist indefinitely. Transient changes include T wave inversion and, crucially, ST segment elevation, figures 30.18, 30.19. Subendocardial non-full thickness infarcts typically don't cause Q waves, non-Q wave MI. Importantly, management strategies like thrombolysis were historically based on this Q wave versus non-Q wave distinction, benefiting Q wave MIs more. A new left bundle branch block, LBBB, on the ECG in the context of ischemic pain should be treated as an AMI equivalent. It masks Q waves and ST changes. And remember that crucial point. A normal ECG early on does not exclude AMI Q waves, can take hours or even days to develop.
And cardiac enzymes, biomarkers.
The patterns are shown in figure 30.21. Larger infarcts tend to produce higher enzyme levels. Troponin I or T are preferred. They start rising 3-12 hours after onset, peak around 24 hours, and stay elevated for 5-14 days. They can also be positive in severe unstable angina and raised in other conditions like aortic dissection or severe kidney impairment. You might need to wait up to 10 hours for a confidently negative troponin. They aren't useful for detecting a reinfarction soon after the first one because they stay elevated for so long. The reference interval is very low, 0.1 GL typically. Creatinine kinase, CK, rises earlier, 6 to 8 hours, peaks at 24 hours, and normalizes by 48 hours. The CK-MB fraction, if 15% of total CK, is more specific for myocardial necrosis than total CK, which can be raised by muscle injury elsewhere, like IM injections.
Other investigations.
Technetium pyrophosphate scanning can show hot spots in the infarcted area from about 24 hours up to 14 days after onset, useful sometimes, especially with LBBB. Echocardiography helps when other tests are non-diagnostic, showing wall motion abnormalities. But sometimes if ECG and enzymes are initially negative, but the clinical picture is strongly suggestive, the clinical diagnosis might be the most reliable guide initially.
Okay, management of acute coronary syndromes.
Yeah.
ACS. General principles.
Immediate medical attention if suspected. Pre-hospital goals. Make a diagnosis, assess risk and stability, get a 12-lead ECG ASAP, mobile coronary care units if available. In hospital, the aim is to achieve coronary perfusion and minimize infarct size as quickly as possible. Prevent or treat cardiac arrest, have a defibrillator ready. Optimal treatment is in a coronary care unit, CCU, with continuous ECG monitoring for at least the first 48 hours, IV access, consider oxygen only if hypoxic, that's 94%. Relief of pain and apprehension is critical, caring empathy matters. Give aspirin 300 milligrams chewed or sublingual ASAP if no contraindications. Consider early beta blocker and ACE inhibitor if no contraindications. For STEMI, the absolute priority is reestablishing flow ASAP either with thrombolysis, clot-busting drugs, or primary angioplasty stenting, PCI. Rescue angioplasty might be needed if thrombolysis fails in large infarcts.
Hospital management.
Confirm the ECG diagnosis, STEMI versus NSTAKES. Send blood for cardiac enzymes, troponin, urea, electrolytes. Get an urgent cardiology consult for risk stratification and to decide on the best reperfusion strategy, usually coronary angiography leading to PCI, CABG, or medical management thrombolysis, depending on availability and timing.
Management of STEMI.
The optimal first-line treatment is urgent referral to a cardiac catheterization lab, cath lab, ideally within 60 minutes, golden hour, for angiography and primary PCI. Best outcomes if done by an experienced interventional cardiologist. The principle is rapid reperfusion. Adjunctive therapy is crucial. Dual antiplatelets, aspirin plus a P2Y12 inhibitor like clopidogrel, ticagrelor, or putresigrel, anticoagulation like LMWH or unfractionated heparin, a statin, and an ACE inhibitor.
What are the urgent reperfusion guidelines regarding timing?
For STEMI, within 60 minutes of onset, PCI is optimal. Within 90 minutes, PCI is acceptable. If these time targets can't be met, e.g. rural setting, delayed transfer, then fibrinolysis, thrombolysis, should be given within 30 minutes of arrival at a facility capable of administering it. If symptom onset was 12 hours ago, reperfusion might still be considered if there's ongoing ischemia, evidence of viable heart muscle, or major complications like cardiogenic shock.
What about first-line management of acute chest pain outside hospital or on arrival?
Get an ECG to classify ACS, STEMSERS. Notify the receiving hospital. ECG is the sole test for deciding on emergency reperfusion. Oxygen 4 to 6 Hellman, only if hypoxic, aims SpO2 90%. Secure 5E access and take bloods, sp-troponin. Give GTN 300 milligrams half-tab sublingually or spray 400 millistrengths. Repeat every 5 minutes, max 3 doses. Remember contraindication with recent PDE5 inhibitor use, and beware hypotension bradycardia. Treat bradycardia with atropine if needed. Give aspirin 300 milligrams, chewed ideally, for pain relief. Morphine, 2.55 milligram IV slowly as a starting bolus, then increments of 1 milligram every 5-10 minutes until pain relief or side effects, max 15 milligrams usually, or fentanyl 25-50 milligram IV can be an alternative. 4V morphine titration is often easier once in hospital,
And management of NSTs, non-ST lativation ACS.
as these patients can still progress to STEMI, so require ongoing monitoring in hospital. Risk stratification is key to guide management decisions whether to proceed early to angiography PCI or manage medically initially.
Let's talk more about reperfusion therapy. Who gets considered?
All patients with AMI should be considered for admission to CCU. The decision between primary PCI and fibrinolysis depends heavily on local protocols and timely PCI availability.
Fibrinolytic therapy, when is it used?
Primarily for STEMI when timely PCI isn't achievable, example, geographic constraints delay. The sooner it's given, the better, ideally within 12 hours of pain onset. The decision should ideally be made by an experienced consultant. Note that PCI is usually not possible for some time after fibrinolysis. Second-generation, fibrin-specific agents like Retiplas, Altiplas, Tenectiplas are generally preferred over older agents like streptokinase, which has issues with prior exposure allergies and is inappropriate for Aboriginal Torres Strait Islander populations due to high rates of prior exposure from strep infections. There are several important contraindications to fibrinolytics: recent stroke, active bleeding, major surgery. Further management after fibrinolysis often includes full heparinization for 24-36 hours, especially after agents like ERT-PA, less so after streptokinase, potentially supplemented by warfarin if there is high embolization risk, large anterior MI, LMWH like enoxaparin or unfractionated heparin are used.
What other treatments go alongside reperfusion for STEMI?
Antiplatelets, aspirin plus clopidogrel usually. Beta blockers started early if no contraindications like atenol or metoprolol. Consider a GTN IV infusion if pain recurs. Early ACE inhibitors within 24-48 hours, especially if there's significant LV dysfunction. Statin therapy initiated early. Correct any low potassium or magnesium levels. Maybe consider magnesium sulfate infusion post-thrombolysis. Consider diuretics like furosemide if signs of heart failure develop.
What about post-AMI drug management with proven benefit?
Definitely. Beta blockers start within 12 hours if possible. ACE inhibitors start within 24 hours after stabilization, especially with LV dysfunction. Dual antiplatelet therapy, aspirin plus clopidogrel, or ticagrelor or prasugrel, depending on specifics. Lipid-lowering drugs, statins. Anticoagulants for specific indications like atrial fibrillation, LV thrombus. Targets are important. BP 140/90 or lower if tolerated. Total cholesterol 4 millimol, LDL-C 2 millimol, triglycerides 2 millimol.
Ongoing management in hospital.
Education and counseling are vital. Bed rest initially, 24-48 hour, continuous ECG monitoring, check electrolytes, K+, Mg+. Early mobilization, usually around day 7-12. Light diet, sedation if needed, start oral beta blocker, anticoagulation if indicated. ACE inhibitors continued, prevent LV remodeling, monitor for psychological issues like anxiety and depression.
And discharge.
Cardiac rehabilitation program referral. Continued education counseling, absolute smoking cessation, weight reduction if needed, regular exercise, walking encouraged. An exercise test might be done pre-discharge. Consider if result changes management. Continue beta blockers, at least 2 years. Continue ACE inhibitors long-term if indicated. Continue dual antiplatelets, aspirin lifelong clopidogrel, usually for 12 months post-ACS, but duration varies. Anticoagulation if indicated, at least 3 months. Statin therapy continued long-term. Arrange follow-up studies, like myocardial perfusion scans if needed.
What about special management issues post-MI? Indications for coronary angiography later.
If angina develops after the MI, if the exercise test is strongly positive, or sometimes considered routinely after streptokinase use.
Management of extensive infarction.
Definitely ACE inhibitors, even without clinical heart failure. Radionuclide studies to assess LV function. Beta blockers have proven value even in severe infarcts if no contraindications. Consider anticoagulation for thrombus prevention.
And recognizing and treating complications of STEMI. Acute LV failure.
Signs are basal crackles, S3, S4 gallop, X-ray changes. Treatment depends on severity. Oxygen, diuretics, furosemide, morphine 3V, GTN, various routes. ACE inhibitors, covered more in Chapter 76 on heart failure.
Cardiogenic shock.
This is a major emergency requiring early specialist input. Might involve adrenaline infusion, other inotropes, intra-aortic balloon pump support, urgent angiography, plus PCI surgery.
Pericarditis.
Can occur in the first few days post-AMI, usually anterior infarcts. Sharp pain, friction rub. Treat cautiously with anti-inflammatories, aspirin, indomethacin, ibuprofen. Avoid anticoagulants if possible.
Post-AMI syndrome Dresslers.
Occurs weeks or months later, often around 6 weeks. Features pericarditis, fever, pericardial effusion. Thought to be autoimmune. Treat as for acute pericarditis.
Left ventricular aneurysm.
A late complication. Can present with heart failure, arrhythmias, or embolization. Signs might include a double apical impulse S4, visible bulge on X-ray, diagnosis confirmed by echo. Treatment involves managing arrhythmias, anticoagulation, heart failure meds, possibly surgical resection, aneurysmectomy.
Right, ventricular infarction.
Can accompany inferior MI, can be life-threatening, needs specific management. Fluids initially, avoid nitrous diuretics.
Ventricular septal or papillary muscle rupture.
Causes sudden severe heart failure with a loud new pansystolic murmur. Poor prognosis, needs urgent assessment for surgery.
Cardiac arrhythmias.
All types are common with STEMI. Treat according to standard arrhythmia guidelines, Chapter 59 defibrillation, cardioversion pacing, etc. Prophylactic 5e lignocaine post-infarct is not indicated anymore.
Anxiety, depression.
Very common. Needs anticipatory guidance, support, education, reassurance, counseling. Anxiolytics or antidepressants may be needed.
Okay, that covers MI management comprehensively. Let's briefly touch on management of the other serious spontaneous causes of chest pain, aortic dissection.
Key is early definitive diagnosis. TOE is often best bedside test. Control blood pressure aggressively if hypertensive. IV nitroprusside or beta blockers often used. Emergency surgery is often needed, especially for type A dissections involving the ascending aorta. Remember, increased incidence in pregnancy.
Pulmonary embolism management.
Investigations we mentioned, CTPA first line, usually VQ, angio, D-dimer, Doppler, ABGs, Wells score. Management requires specialist care, supportive measures, oxygen, etc. Anticoagulation is the mainstay. Direct oral anticoagulants, DOACs, are now often first line, or heparin, IV, or SC, or LMWH initially, often followed by longer-term anticoagulation. Thrombolytic therapy, IV or via pulmonary artery catheter, is reserved for major embolism causing hemodynamic instability. Surgical embolectomy is rarely needed.
Pneumothorax management. Spontaneous type first.
Can be spontaneous, often due to copdasma underlying or traumatic. Most small spontaneous pneumothoraces resolve on their own. For a spontaneous pneumothorax in an otherwise healthy adult, even if quite large, conservative management, observation, analgesia, oxygen if needed, is often appropriate initially, and evidence suggests it's superior to intervention regarding adverse events and hospital stay.
When would you intervene?
Pleural intervention, like inserting a small catheter, is indicated if there's clinical deterioration, falling BP or oxygen saturation, rising pulse or respiratory rate. For recurrent attacks, surgical options like bleb excision or pleurodesis, sticking the pleura together, might be needed. Recurrence rate after a first spontaneous pneumothorax is quite high, 30–50%, mostly within a year. Pleurodesis pretty much eliminates recurrence on that side.
An acute tension pneumothorax.
As we said, this is an emergency. Urgent decompression is needed with a large gauge needle, 12–16G, inserted into the pleural space, typically in the second intercostal space, mid-clavicular line on the affected side. This should then be replaced with a formal intercostal catheter connected to an underwater seal drain.
What about treatment of esophageal disorders, G or RD?
Lifestyle measures first. Achieve normal weight if overweight. Avoid trigger foods, drinks, coffee, alcohol, spicy foods. Eat smaller meals. Simple antacids or alginate compounds like Gaviscon, Mylanta Plus can help. If persistent, then acid suppression therapy. H2 receptor blockers like ranitidine, although availability issues exist now, or more commonly, proton pump inhibitors, PPIs like omeprazole, pantoprazole. Important to reassess need for PPIs after 4–6 weeks and consider deprescribing if possible, especially long-term.
An esophageal spasm.
Can try long-acting nitrates like isosorbide dinitrate or calcium channel blockers like nifedipine slow release. Addressing lifestyle and dietary factors as for reflux is also important.
Let's revisit musculoskeletal causes of chest wall pain, Table 30.9.
Many causes exist, usually diagnosed by history and exam. Includes things we mentioned like costochondritis, muscle tear strains, common after exertion, Tietze's syndrome. Some are uncommon and part of systemic disorders like ankylosing spondylitis. Always consider a fractured rib, including jaw fracture.
Key features.
Pain is aggravated or provoked by movement stretching, deep breathing, sneezing, coughing. Can be sharp stabbing or a constant ache. Costochondritis pain is localized to the costochondral junction.
Management.
Generally conservative. Simple analgesics, gentle massage with topical analgesic creams, sometimes NSAIDs if inflammation is prominent. Local anesthetic injections, sometimes with corticosteroids, can be used for persistent localized pain like costochondritis, but need care not to puncture the pleura. Modified support like an elasticated rib belt can help with rib injuries.
What about posterior chest, thoracic back pain?
Most common cause is musculoskeletal, especially joint dysfunction of the thoracic spine. Probably the commonest specific cause is costovertebral dysfunction strain of the joints where the ribs meet the vertebrae. This back pain can sometimes refer pain simultaneously to the anterior chest or even the abdomen.
Acute thoracic back pain.
Usually vertebral dysfunction, but always consider serious causes. Bone disease like compression fractures, especially osteoporosis, and those life-threatening visceral or vascular causes we discussed, MI, dissection, PE, can sometimes present with back pain. Refer to red flag pointers, Table 27.3, and management in Chapter 27. Note that intervertebral disc protrusions causing acute pain are actually rare in the thoracic spine, T2 to 9, and rarely a penetrating peptic ulcer can present primarily as mid to lower thoracic back pain.
So, when to refer a patient with chest pain?
Obvious or suspected MI, especially if extensive or complicated, need to transfer to a major center for MI complications like rupture of the septum or papillary muscle, ventricular aneurysm, refractory arrhythmias, or cardiogenic shock. Persistent angina after an MI, angina not responding adequately to medical therapy. Unstable angina definitely needs hospital admission. Angina lasting 15 mins unresponsive to sublingual nitrate requires urgent hospital admission. Suspected or proven PE, dissecting aneurysm, or other serious life-threatening problems after initial first-line measures like decompressing a tension pneumothorax, and suspected esophageal or other GI disorders like a duodenal ulcer, likely needing endoscopy or further gastroenterological evaluation.
Finally, Murtagh provides some concise practice tips. Can you summarize those?
Key takeaways. Treat all sudden acute chest pain as potentially cardiac and fatal until proven otherwise. Careful history is the absolute basis of diagnosis. Don't forget mitral valve prolapse as a cause of recurrent pain, especially in younger women. Confirm with echo. Be aware that calcium channel blockers can cause peripheral edema. Don't automatically attribute it to heart failure. Remember, esophageal spasm pain can be extremely severe and mimic MI closely. And confusingly, esophageal spasm can also respond to GTN, just like angina. Lastly, while spinal pain is common, true intervertebral disc protrusions causing severe sudden thoracic pain, T29 region, are very rare.
Fantastic. That brings us towards the end of this incredibly detailed deep dive. I think the key message really is that chest pain demands a systematic approach, always prioritizing the exclusion of those life-threatening conditions. It reinforces the absolute importance of a thorough history, careful examination, and the appropriate use of investigations.
Absolutely. And understanding the nuances of the different presentations like atypical MI, silent PE, or that tricky spinal referral mimicking cardiac pain is invaluable, both for immediate patient care and definitely for fellowship exam preparation.
So as a final thought for you listening, how will you integrate this comprehensive overview into your clinical practice and your exam prep? Maybe think about creating your own differential diagnosis checklist or algorithm for chest pain. Or perhaps spend some time reviewing ECG findings related to the various causes we've discussed today.
That constant reflection and refinement of approach is key.
Couldn't agree more. Thanks for joining us on the Deep Dive.